So let's start with talking about what sleep is generally. It's a mental and physical state of rest. Usually we're inactive. We're relatively unaware of the stimuli around us in our environment. And this is usually accompanied during sleep by a decrease in our body functions. The body temperature goes down, blood pressure decreases, respiration rate decreases. Our systems essentially are supposed to go into idle mode during sleep, but it's very important to note that the brain remains quite active during sleep. I'll tell you why that is here in just a moment. The structure of sleep is something that's really pretty important. As you may know, we have different stages of sleep, and these are divided into two distinct types. There's rapid eye movement sleep, or REM sleep. REM sleep, by the way, is also when we do our dreaming. So REM sleep or dreaming sleep is one type of sleep. And then there's non-REM sleep. Non-REM sleep is broken down into stages 1 and 2 and 3. 3 is actually the deep stage of sleep that's most restorative. And then you have REM sleep, and people cycle through these different stages of sleep in about 90 to 110 minute cycles. And typically this occurs about 4 to 5 times per night. So in order for us to feel rested and restored, we need to cycle through these different stages of sleep as part of our sleep phase. Talking about when we sleep, our body responds to what are called circadian rhythms. There's a part of our brain, it's got a really cool name. It's called the suprachiasmatic nucleus. And this part of the brain, which is a mouthful, holds the master clock or biological clock that tells us when to be awake and when to be asleep. Light and dark cues really kind of guide that. So as human beings, we are diurnal. What that means is we're meant to be awake and alert during the day when it's light out, and we're meant to be asleep at night when it's dark. There are animals out there, as you probably know, that are nocturnal, that are actually awake at night and asleep during the day. But we as human beings are not built to do that. Sleepy peaks, as I call them, occur twice daily. Of course, one of the sleepy peaks that we get is supposed to happen in the evening, right before bedtime. That's what usually pushes us off to sleep. But we also have a second sleepy peak earlier in the day. It's typically several hours earlier than when we get sleepy in the evenings. This is that afternoon slump that you might have experienced. You ever been in a meeting or doing something in the afternoon and you feel really sleepy and tired and you're wondering what's going on with me? That's actually really normal. There's a name for it, and it's called the circadian trough. So it's kind of a little dip in our energy level that typically happens anywhere from early afternoon to late afternoon. It's not so abnormal to have this, but you should be able to make it through that circadian trough, that little dip in your energy level, and out the other side okay to finish out the remainder of your day. Daylight generally triggers wakefulness, and darkness prompts sleep. And one other important point to note is about something called a sleep debt. This accumulates over time with our need for sleep. So if I'm a guy that needs 7 hours of sleep per night, and I get all rested up over the weekend and catch up on my sleep, and Monday rolls around and I have a particularly busy day and I'm up really late Monday night, or my sleep is disrupted in some way and I only get 5 hours of sleep on Monday night. Now at that early point at the beginning of the week, my sleep debt is already 2 hours because I shortchanged myself by 2 hours on Monday night. The funny part about that is, just like with any other kind of debt, the sleep debt needs to be paid down. And this is typically done on weekends or days off when people are able to sleep in a little bit. Teenagers, by the way, are famous for building up and accruing a big sleep debt. They typically pay down their sleep debt on the weekends as well. And if you have a teenager, if you've seen a teenager do this, or if you've been a teenager that has done this, teenagers can sleep an inordinate amount of time on the weekends because they often have a big sleep debt. So there are a few things that really kind of control when we sleep. There are the circadian rhythms, the master clock in the brain that tells us when to be awake, when to sleep. The homeostatic drive is that natural sleep debt that builds up over time. So if we shortchange ourselves a number of nights in a row, we're going to naturally get sleepier and sleepier as the days go by. And then there's a third factor that has a fancy name called allostatic signaling. This is all about what's going on in our environment. And that might include what's going on internally and emotionally, and in terms of our thoughts and behaviors as well. What I mean by this is the brain really has two signaling systems when it comes to sleep. There's the wake signaling system, and then there's the sleep signaling system. And these two systems are mutually interdependent. What I mean by that is when one system is activated, the other is suppressed, and vice versa. So when that wake signaling system is activated in the brain, we're going to be awake and alert, and the sleep signaling system is suppressed. Vice versa, if the sleep signaling system is activated in the brain, the wake signaling system is turned off or suppressed, and we're going to be asleep. So it makes sense, right? If you think about it from a logical standpoint, we can't be awake and asleep at the same time. So really, how these systems get activated really can have a lot to do with what's going on in our environment. So if I have a mattress or a bed that's uncomfortable, if I have a room that's not the right temperature, if I have a street light that kind of blares through my window at night and gets in my eyes, or some noise in the room, there's oftentimes a bed partner that can disrupt our sleep. So a spouse or a significant other that might, for example, snore. That's a very common thing in our culture in the United States. Snoring can be loud and disruptive. And it can fragment the person's sleep in bed next to us. In fact, there's a name for it in the sleep world. It's kind of a funny name called spousal arousal syndrome. It sounds like something exciting and titillating, but it's actually not at all. It's very annoying to have a spouse who snores or might have limb movements and other type of things going on during sleep that can disrupt our sleep pattern. Could also be that I have some stressors going on in my life. I know when I was in early recovery, there was some wreckage to clean up from before I had gone into treatment. And the stressors in early recovery were not really facilitating my getting to sleep and staying asleep very well. So kind of the mental and emotional pieces of all of this can cause that wake signaling system to be activated and turning off the sleep signaling system, such that I was having trouble getting to or staying asleep. So let's talk about why we sleep. First and foremost, for restoration. We get rejuvenated from sleep. The brain is also, remember, very busy during sleep, performing a lot of tasks. I'll give you an example. The brain is busy replenishing certain brain chemicals like serotonin. There's one called serotonin that's responsible for regulating mood and anxiety symptoms, also responsible for our storing short-term memory into long-term memory, etc. So all of those things happen during sleep and help us to become restored. There's also the functioning factor. The amount of sleep we get and the quality of sleep we get will have a direct impact on how I feel during the day, how I function during the day. This is really a necessary biological function for all of us as human beings. And if we're not getting enough sleep in terms of the quantity or our quality of sleep is poor, there are a lot of negative impacts potentially on our health and our quality of life. The fact is that we in the American culture do not prioritize sleep quite enough. It's estimated that over 60% of Americans are sleep deprived at any given time. And other literature out there suggests that better than 50% of adult Americans will meet diagnostic criteria for insomnia at some point in their lives. This has resulted in some legislation related to sleep in some states. You may be aware of the old research that was done a number of decades ago that showed that someone who is sleep deprived is actually more impaired operating a motor vehicle than someone who's intoxicated on alcohol. That's actually a true thing. So legislation has been passed in certain states around sleepy driving, just like it has around drunk driving. So how much sleep do we need really? It's kind of a flimsy answer to give people, but generally most adults need in the 6 to 8 hour range. There are some people who need less than 6 hours of sleep and can get by and function fairly well. Believe it or not, there's a name for them in the sleep world. They're called short sleepers. And then there are people on the other end of the spectrum who need more than 8 hours of sleep, that are long sleepers and need much more sleep on a nightly basis for various reasons. I won't bore you with these other bullet points on this current slide, but it just gives a layout of how much sleep we need all the way from infancy up through the teenage and early adult years, into adulthood. Then by the time we reach adulthood, generally 6 to 8 hours is in the normal range. So let's talk about what a sleep disorder is. Believe it or not, there are now almost 100 sleep disorders out there. The sleep disorders that are most commonly seen cause a disruption to how we sleep, or the quality of sleep, the quantity of sleep, or how much sleep we get, and then the timing of sleep, when our sleep phase occurs. And that's very, very important. I'll tell you why here in just a few moments. There are a handful of sleep disorders that are most common, and we'll talk about these tonight rather than bore you with all of the off the beaten path ones that are not very common at all. We'll focus on the ones that folks are most likely to experience symptoms in. And these are insomnia. It's first and foremost, by far and away, the most common sleep disorder out there. Circadian rhythm disorders, disorders that disrupt the when of when we're sleeping. Sleep disordered breathing, like sleep apnea, which is usually associated with snoring. And then there are limb movement disorders like restless leg syndrome and periodic limb movement disorder. The two often go hand in hand and involve leg or limb movements around sleep and during sleep. So we'll talk about these types of disorders, what the signs and symptoms are, and how we might fix them. So let's talk first about insomnia. Plain and simple, trouble getting to sleep, trouble staying asleep. People often have trouble with both. It can also be just a perception of poor quality sleep. In order to be diagnosed with insomnia, it has to happen a minimum of 3 nights per week, and it has to happen for a duration of at least 3 months for someone to meet criteria for insomnia. It also has to be associated with distress. I've never met many people who passively accept insomnia, but it can be distressing to not be able to sleep, and impaired functioning. They don't feel well during the day. Typically, they feel fatigued or sleepy, etc. So really, this slide has a lot of fancy language in it, but what it means is when we have enough trouble sleeping, enough nights in a row, we can get to a point where we can simply cross the threshold into our bedroom. We can look around the bedroom and we can think to ourselves almost as an automatic thought, oh no, here we go again. What's tonight going to be like? Another night of tossing and turning? Is it going to take me 2 hours to get to sleep again? Am I going to be waking up during the night again like I have been in recent nights? I've got A, B, and C to do first thing tomorrow morning. I can't be tired tomorrow of all things. Please not tonight. So here a person has stepped into their bedroom, looked around the bedroom, had these automatic thoughts, and they have already catastrophized themselves out of a night's sleep before they've even touched their bed. And that's this conditioned kind of state of arousal that we can get in by simply entering our bedroom. And the bedroom becomes a battleground for people with insomnia. It actually is a stressful event to think about trying to go to sleep. And that really becomes the problem. It increases our alertness at bedtime, which is the exact opposite of what we want. It decreases what we call our sleep efficiency, our ability to get to sleep quickly and stay asleep. And typically you don't see daytime sleepiness associated with this. You do see daytime fatigue. So oftentimes when I used to see a lot of insomnia patients across the board, they would say, when I asked them if they nap during the day, they'd say, boy, I wish I could, but I'm not able to nap during the day. I'm just dragging around all day long and I'm really, really tired, but I'm not outright sleepy. This model here shows really what I was just talking about. You know, insomnia can be a normal human reaction to stress. So if I'm going through a divorce, if I'm going through a job change, if I've got other stressors in my life, if I'm in early recovery, for example, insomnia is a fairly normal human reaction to that. But when the trigger for the insomnia starts to dissipate or go away, so should the insomnia. But the problem is we go from being worried about whatever the initial event was, the triggering event, and worrying about that and that impacting our ability to sleep, to, oh no, I can't sleep becomes the central worry. So now again, entering the bedroom becomes kind of a stressful event. Whether or not we're going to be able to sleep at night becomes a big stressor, and people start to worry and fret about their sleep front and center. And that happens as a migratory effect over time and can become chronic insomnia for some people. They have trouble with years of insomnia as a result of this pattern. So the big daytime complaints you see with insomnia are fatigue and sluggishness. Occasionally you will find folks that are actually sleepy and nod off during the day. Physical complaints, aches and pains are very common in people with insomnia. Disturbance in mood, anxiety symptoms, difficulty focusing, concentrating, memory issues, particularly short-term memory, causes impairment in performance. So at work, at school, at home, it might make it difficult to stay focused and perform when I'm walking around tired because I'm sleeping poorly. And then, of course, front and center, as I mentioned, becomes the stress about poor sleep. The other consequences we see are decreased quality of life. This is reported across the board in the research out there. Medical problems are much more likely to be present in people with insomnia. It's very expensive to try to treat. There are healthcare costs associated with this. When it comes to work, you see a lot of what we call absenteeism, where folks might call out of work because they did not sleep the night before and they're awfully tired and can't make it into work, or presenteeism. They actually do make it into work, but they're not altogether there, if you know what I mean. The lights are on, but nobody's home. Decreased productivity, of course, can result from that. There's an increased risk for developing psychiatric disorders like major depressive disorder or generalized anxiety disorder. And believe it or not, there's a huge increased risk for accidents. When people aren't focused, they're tired and are foggy. Commuting to work, driving an automobile, for example, is a really tough prospect. There's also a risk for accidents on the job. So people who work in production, like in a factory or a plant, for example, are at increased risk for accidents as a result of insomnia. It's the most common sleep complaint in the industrialized world. I would like to focus your attention on the fact that this is the industrialized world we're talking about, where we're go, go, go 24/7. As we migrate more and more toward a 24/7 society, it's really challenging. We just don't see these kind of problems in third world countries where they're not constantly on their phones or having screen time and those types of things. You see symptoms of insomnia. These numbers are a little low now, but up to 50% of people. And the complaint with distress or impairment, in other words, they meet the diagnostic criteria for insomnia, is now somewhere in the 25 to 30% range. As I mentioned to you earlier, some of the scientific evidence out there suggests that over 50% of adult Americans will meet criteria for insomnia at some point in their lifetime. So you just don't hear these kind of staggering numbers about other medical disorders. Insomnia is very, very common in our culture. The treatment for insomnia can be drug treatment or pharmacologic treatment. It can also be non-pharmacologic or non-drug treatment that is most indicated for a person. And then there's a combination type therapy. You can do drug and non-drug type treatments, and we'll talk about what those treatments look like. Really, the treatment of choice when it comes to non-drug treatments is something called cognitive behavioral therapy, or CBT. CBT has three main components to it: how we think, how we act, and how we feel. That really kind of summarizes us as human beings, right? How we think, how we act, and how we feel. So CBT kind of focuses on those three main factors and then targets certain tools to help fix your sleep. Sleep hygiene is healthy habits related to our sleep and has everything to do with things like caffeine consumption, what our sleep schedule is like, what our environment's like, etc. Stimulus control has to do with our bedroom being a safe haven for us to sleep in. So if I'm having trouble sleeping, I'm tossing, turning, getting frustrated, instead of pulling out my phone or engaging in other activities to try to force myself back to sleep, we actually have people who are having trouble with insomnia get up, get out of the bedroom, go to another room, do something boring, dull, and monotonous under dim light. Don't expose yourself to bright light, right? The light cues. And return to bed when you're sleepy and only when you're sleepy, or when your mind has cleared and only when your mind is cleared, and repeat that as necessary. Now, I know that sounds crazy, and I've gotten looks from people when I've suggested that to them, but it is a huge helpful tool for getting the bedroom kind of reconditioned as a place of relaxation and restoration where we can have success at sleep. Sleep restriction has to do with giving a prescribed bedtime and a prescribed wake time and sticking to that schedule 7 days a week. I know that doesn't sound very appealing if you'd like to sleep in on the weekends, but it's actually not necessarily good for that clock in our brain if we're giving it a moving target to shoot at by changing up our bedtime and our wake time from day to day. Cognitive therapy has to do with challenging some of the dysfunctional beliefs and thoughts I have around sleep. One of them, for example, might be the kind of what I call black and white thinking around sleep that a lot of us have. For example, good night sleep equals good day. Bad night sleep equals awful day. It's just not true, right? And I can think of a lot of examples of nights on which I did not sleep particularly well, but I felt okay the next day, surprisingly good. And likewise, I can think of a lot of nights where I thought I slept really, really well, and I was just kind of dragging around and tired the next day. So it's just not a black and white equation like that. And then circadian rhythm entrainment has to do with starting to train that master clock in our brain around what time we'd like to go to bed and what time we'd like to be awake on a day-to-day basis. So let's talk about circadian rhythm disorders. We've covered insomnia. Circadian rhythm disorders can sometimes look like insomnia, but this is also a recurrent pattern of sleep disturbance. And this is really due to a misalignment of our sleep schedule, when it is that we're sleeping, with when we're supposed to be sleeping. Remember, human beings are diurnal. We're supposed to be awake and alert during the day when it's light out, and we're supposed to be asleep at night when it's dark. This really can result in a lot of problems getting to sleep, staying asleep, and also feeling bad during waking hours. Also, just like the other disorders associated with distress or impaired functioning. So one of the circadian rhythm disorders that's very common is called delayed sleep phase syndrome. This is the night owl syndrome. So again, teenagers are famous for having this delayed sleep phase syndrome issue, where their bedtime gradually creeps later and later and later at night. It's due to a couple of things. Number one, there are biological reasons with the hormone changes that go with the teen years. They need less sleep typically, and the bedtime gradually migrates later as part of that. But the other reason is environmental in nature. These days, if you think about it, if parents go off to sleep and a teenager suddenly has the house to him or herself, there are all kinds of exciting things that they can get into, especially with digital devices nowadays. So they've got an iPad or some other tablet or their smartphone, or they can watch TV or stream movies or get on the phone or message with folks. They can eat what they want in the house. They kind of have the house to themselves. So there's an environmental motivation to staying up later as well. And guess what? Teenagers have the earliest school start time of anyone in the developmental spectrum. So they start school earliest. It's actually resulted in some legislation being passed in some places to start school later for teenagers because of this delayed sleep phase syndrome problem they have. The result is they accrue a sleep debt throughout the week, and they end up sleeping away the weekends as a result of the delayed sleep phase syndrome. On the other end of the spectrum is something called advanced sleep phase syndrome. This would be the older adult population, those in nursing homes and the elderly. These are folks that go to bed really, really early, early in the evening. And then as a result, lo and behold, they wake up in the early morning hours and can't get back to sleep. So their sleep period is kind of shifted earlier in the day. So I've got two parents. My father's also in recovery for almost 40 years. And he contacted me at one point and said, I'm having trouble sleeping. And I said, well, tell me about that. When are you going to bed? And he said, oh, I'm asleep by, 8 o'clock or so. And I said, all right, are you getting to sleep okay? He said, yep. Are you staying asleep? And he goes, well, until about, 3 in the morning. And then I wake up at 3 in the morning and I can't get back to sleep. And I said, well, Dad, if you do some math on that, that's actually 7 hours of sleep that you're getting in a nice block of time. That's pretty doggone good. So his sleep schedule is misaligned with when he would like to be asleep. And you see this in nursing homes a lot, where they get up at a really, really early hour, eat breakfast, they're eating lunch by 10 a.m. and dinner by late afternoon, and then they're off to bed again. So it creates this advanced sleep phase syndrome phenomenon that we see. One that's really, really common that falls into the circadian rhythm disorders category is shift work sleep disorders. So there are 156 million working Americans, believe it or not. And believe it or not, almost a quarter of them, over 37 million, are shift workers. These would be people who work at night when we're supposed to be asleep, and then they try to sleep during the day. The largest areas in which you see shift workers are listed here. You see it across all different types of industry. And again, as we move more and more toward a 24/7 society, really the demand for round the clock workers is going to increase, and we'll see more and more shift work being done. The problem is that it's really, really dangerous to do shift work disorder. It causes decreased alertness, poor focus, and concentration during the hours when we're awake. There are safety issues at work and performance issues at work, not just in the workplace, but also commuting to and from work. Again, high risk of motor vehicle accidents and folks who aren't very alert when they're driving. There's impaired social functioning. There's a phenomenon called anhedonia, or loss of interest in things that would normally bring us pleasure. And you see this commonly in shift workers. There are family obligations that they either are unable to meet or have to meet, and it disrupts their sleep pattern. So you're kind of at this crossroads where if you go down one pathway, you meet your family obligations. Now I'm sleep deprived chronically. If I don't, it doesn't go over too well with my partner. And the divorce rate resultantly is 57% higher in shift workers. Can you believe that? The other part about shift work is there's a dramatically increased chance that these folks engage in misuse of substances or outright substance abuse. So I've got a sister that for years did third shift work as a nurse, and she would get off work at 7 a.m. and she and her counterparts at the hospital would then head off to happy hour to have a few cocktails first thing in the morning. Sounds ludicrous, doesn't sound crazy to a guy like me, but to most normal people it would. But if you think about it, that was their happy hour. They were just getting off work. And what they found by and large as a group was if they had a few drinks, it helped them get off to sleep, right? So people would get in this habit of trying to kind of sedate themselves to sleep. Alcohol is very common in shift workers, and then stimulant medication to kind of wake us up and get us alert when we need to be awake and alert, particularly during those nighttime hours when, quite frankly, our brain wants us to be asleep. So there are many health problems that can come from shift work sleep disorder. Obesity, weight gain is very common in these folks. Heart disease, high blood pressure, blood sugar issues, metabolic syndrome is associated with that. Gastrointestinal disorders like reflux and other GI disorders, reproductive disorders, a higher rate of cancer, and then depression and anxiety, very common in the shift work disorder population. So the way we treat these disorders is first and foremost to educate the person about these types of things. There is something you can get over the counter at any pharmacy or grocery store called melatonin. Melatonin is actually a hormone that's released by a gland in our brain at night when we get that big sleepy peak in the evenings that I mentioned at the outset of this presentation. There are some things that happen to our body temperature. It goes up, then it goes down, and then this gland releases a hormone called melatonin into the bloodstream, and that is what pushes us off to sleep. Well, you can get melatonin supplements in the store. Typically, people have tried the old regular formulation. They don't realize there's a timed release formulation, which is fantastic. And typically people have tried too low of a dose. They take 1 or 3 milligrams, but a timed release version of melatonin that releases slowly into your system keeps you asleep in a nice block of time at a 10 milligram dose and taken 45 to 60 minutes before you're aiming to get to sleep can be amazing for your sleep quality. There's also something called light therapy. There are these light boxes, and these days they even have these bright light bulbs. The brightness of light is measured in something called lux, L-U-X, and these have to be 10,000 lux or more. It's almost like tanning bed bright light. But exposure to bright light therapy, particularly when you first wake up and you want to be awake and alert and kind of reset your circadian clock, can be an amazing help. It's also the reason why they have really, really bright lights in factories and things like that when they have third shift workers working during those hours, because it helps to keep people awake and alert. Bright light therapy delivered by way of our phones and other screen time, et cetera, by the way, is awful for our sleep. And guess what? A lot of us have our noses in our phone at bedtime. So imagine the light exposure going into the photoreceptors of our eyes, sending a signal back to that wake signaling system in the brain, telling it to light up, and our brain turns on. Now, there are all kinds of blue blocker things you can put and screen filters and those kind of things these days that can help with some of that. But nonetheless, light therapy used for the right reason to wake our brain up and get us awake and alert when we want to be can be very helpful, particularly with circadian rhythm disorders. And then there are behavioral interventions. We give people a pretty strict sleep schedule that's prescribed: bedtime, wake time, some rules and regulations related to caffeine use and medications and those types of things, being able to relax and wind down for a certain period before bed, all of those great sleep hygiene rules. And scheduling naps is actually an amazing help for people with circadian rhythm disorders. The power nap is not a myth. Actually, a 10 to 20 minute nap can be very, very powerful. I would give this disclaimer. The reason we recommend short naps is because you don't want to go 30 minutes or longer with a nap, because you risk running into REM or dreaming sleep. When you run into that deeper kind of different stage of sleep, you'll oftentimes wake up feeling foggy and like there are cobwebs in our brain. You ever done that? You take a nap and you wake up thinking, man, I think I overdid it. And you just can't quite get back on track for the rest of the day. That's because you did overdo it. And you probably went into some of those other stages of sleep, like REM sleep, where you wake up feeling foggy, and it's hard to shake that for the rest of the day. So if you can keep the nap to a reasonable amount of time, typically 10 to 20 minutes, it can be an amazing boost to your energy level, and actually typically will not impact your ability to sleep later that night. So we've covered now insomnia and circadian rhythm disorders. We'll talk now about sleep disordered breathing. Boy, this is a hot topic. Obstructive sleep apnea is probably a sleep disorder that you've heard of. Apnea is from the Greek meaning want of breath. This is aptly named because apnea is a repeated stoppage of breathing or a reduction in breathing during sleep. It's due to a collapse in the throat or upper airway area. And the two hallmark signs of sleep apnea are, number one, first and foremost, snoring, and it's typically loud snoring, the kind that'll get an elbow thrown into your ribs or get you kicked out of the bedroom kind of snoring. And it's almost always associated with daytime fatigue or sleepiness. These folks are actually outright sleepy during the day and will nod off oftentimes. So what happens with sleep disordered breathing is we drift off to sleep. The muscles in our body relax. That includes the muscles around the throat area or the upper airway. That upper airway starts to relax down and then collapse. And there's a vibratory effect as the person is breathing through that collapsed airway. And that's what produces the snoring sound, is that vibratory effect in the walls of that upper airway. So snoring is a form of apnea. It is a partial apnea, or what's called a hypopnea. Now, other times you'll hear somebody pause in terms of their breathing. Maybe you've even woken yourself up with this, or you've seen it in other people and witnessed this, where you hear them breathing, they start snoring, it gets louder and louder, and suddenly there's a pause. It's quiet, and it's kind of unsettling to hear this. I've seen people do this, believe it or not, for minutes at a time. What happens is their oxygen level starts to drop. The brain senses this, goes into survival mode, and releases norepinephrine. It's adrenaline into the bloodstream. This is your brain's way of giving you a kick in the butt and saying, hey, wake up and take a breath. So you'll hear the person kind of, they'll snort, they'll gasp, they'll carry on, they'll take in a few deep breaths, get that oxygen level back up, they drift back off toward deeper sleep, and this cycle repeats over and over and over again. Believe it or not, some of this dramatic sounding breathing issues during sleep can be pretty normal. You have to stop breathing 10 or more times per hour to be diagnosed with sleep apnea. I know that sounds ludicrous, because if you do the math on that, that's several times an hour that you can have some of these respiratory events and not really meet the diagnostic criteria. But that's actually true. 10 or more times per hour of having these respiratory events warrants a diagnosis of sleep apnea. And it's often worse when we're sleeping on our back, what's called the supine sleeping position. You can imagine why. The base of the tongue can collapse over that airway pretty easy when we're on our back. And in REM or dreaming sleep, nature's way of keeping us from acting out our dreams is to have what's called muscle atonia in place. We really go into somewhat of a state of paralysis during dreaming sleep or REM sleep, and that keeps us from acting out our dreams. Well, it also causes that upper airway to collapse more easily during that particular stage of sleep. So people often have worse snoring and apnea during that particular stage of sleep. The consequences of this, of course, are fragmented sleep. The sleep is kind of chopped up, constant arousals from sleep. So if somebody were standing next to your bed and nudging you or putting their hand over your nose and mouth every so often during the night, you would probably expect to feel tired from that. The other thing it causes, because of the constant norepinephrine adrenaline release to get you breathing again, is it drives the blood pressure up. Well, that adrenaline is also counter-regulatory to insulin, so it impacts our blood sugar levels. So people can be borderline diabetic or be diabetic outright type 2 diagnosed in their adult life as a result of this. Short-term memory loss, morning headaches, morning dry mouth, depression and anxiety symptoms. Acid reflux is a big one. It can cause sexual dysfunction. Weight gain. There are two hormones that are regulated in deep sleep. They regulate our metabolism in turn, and our metabolism slows when we're not sleeping well. So people typically gain weight over time when they have any sleep disorder, not the least of which would be sleep apnea. Of course, decreased productivity at work and school, and this can often be associated with a family history. So if one of your parents was a loud, famous kind of snorer like me, my dad snored for years, he had sleep apnea. We could hear it from other rooms of the house even. So it can run in families as well. But ultimately, the thing about snoring that's not so funny is it causes an increased risk down the line for strokes, heart attacks, certain types of heart disease, and can put a person at dramatically increased risk for motor vehicle accidents. The research out there has shown that someone who has untreated sleep apnea has a 9 times risk for a motor vehicle accident as someone who does not. Isn't that amazing? They're 9 times more likely to have a motor vehicle accident with untreated sleep apnea. So a lot of legislation has been passed related to this, particularly in the trucking industry. If there are signs and symptoms of sleep apnea, they're now mandated to go get a sleep study and treat sleep apnea if they do have it, to be safe on the road. So some of the facts related to sleep apnea, it's estimated that 55 million Americans have some shape or form of sleep apnea. And guess what? It's kind of like with addiction. The large majority of them go undiagnosed for various different reasons. It is associated with weight. If you think about it, when we gain weight, one of the first places we can gain it's kind of in our face and neck. When the neck thickens up, it restricts or crowds that airway. And it's less of a stretch for that airway to collapse down at night when it's more restricted or crowded. If the airway is restricted for other reasons, like big tonsils or a thick tongue base or a long, soft palate, those kind of things, it can also increase the chances from a physiological perspective that a person is going to snore and have sleep apnea. Speaking of weight, boy, this is an old slide from 2007. This is when we really started to see a big impact of the obesity epidemic. You can see here that in the 30% obesity rate or higher, this is kind of clustered around the southeastern United States in 2007, and it has grown dramatically since then, but this is when it really kind of started. Sleep disordered breathing, by the way, look where the states are that are most lit up related to having sleep apnea and insufficient sleep, clustered around the southeastern United States. By the way, opioid prescription rates also the highest in the southeastern United States. So you can kind of see an overlap on the map of all of these different health problems that relate to addiction, sleep, insufficient sleep, and then attendant health problems. And it's really no mistake that a lot of these states overlap. Going back, oh gosh, I don't know, a decade or so ago, the top 10 states in obesity, which are listed here, Tennessee, where I live, is number 3. Really, the order of these has changed in recent years, but for the most part, it's roughly the same 10 states that share this top 10 list. They just kind of change up the order from year to year a bit. So again, southeastern United States is really where you see a lot of the challenges. So let's talk about the positive side, the treatment of sleep apnea, because there is a treatment for this. There's something called PAP, or you might have heard CPAP as or BiPAP even as an acronym. The PAP or PAP part is for positive airway pressure. CPAP is continuous positive airway pressure. BiPAP is bi-level positive airway pressure. But what this is, small pressurized mask that fits under the nose or over the nose, delivers air pressure continuously into the nasal passageway, goes down to the upper airway, and holds that upper airway open so that it eliminates sleep apnea. To this day, it is still the gold standard for treatment of sleep apnea. And you can see in the lower picture on this slide, the gentleman here who looks like he's sleeping pleasantly with something strapped to his face. That's actually called nasal pillows. These days, they've got these smaller masks that don't really cover your face at all. They just fit gently underneath the nose, just into the nostril, and deliver air pressure fairly gently to keep that airway open. Surgery is an option, but it's not recommended for adults. If someone has Whopper tonsils that are crowding their airway and they're still fairly young, as you probably know, getting your tonsils out as an adult is a whole different ball game than it is getting your tonsils out as a child. So if it's a child or an adolescent, surgery is the first line of treatment for sleep apnea. As an adult, it's not. CPAP is the first line of treatment. There's something called an oral appliance. It's a mouthpiece, and there's an example in the upper picture on this slide of an oral appliance. They're also called mandibular advancing devices, your mandible being your jawbone. So this actually pops into your mouth and holds your jaw forward just a bit so that the base of the tongue is pulled forward and that airway remains open. These are best for people who have milder cases of sleep apnea or sleep apnea that mostly occurs when they're sleeping on their back. Positional maneuvers has to do with how we sleep. There are these cool little devices you can get online, like a t-shirt you wear that has what looks like a shark fin on the back of it. Hard to roll over and sleep on your back when you're wearing that t-shirt. There are certain types of positional body pillows too you can use to keep yourself from rolling on your back. Again, this would be mostly for people who have challenges with sleep apnea only when they're on their back. And weight loss is a huge help for treating sleep apnea. When we lose weight, just like when we gain it, one of the first places that we'll lose weight is in our face and neck, and it opens that airway up a bit and decreases the likelihood of having sleep apnea. So last but not least, let's talk about these limb movement disorders. RLS stands for restless leg syndrome. Man, this is a tough one for people. It's an irresistible urge to move the legs, usually. It can also be in the arms, but not very often. It's usually in the legs. And people describe this as a creepy, crawly feeling in their legs. I've heard people say it feels like I have coke in my veins. It feels like there are ants crawling on my legs, etc. It's usually something that's present in the evening and gets worse as the evening goes on. Almost always happens ironically when it rests. So when a person gets into bed and tries to settle down, and they almost always report that moving the legs helps. In fact, I've seen people that have worn holes in their sheets by moving their legs, trying to find symptom relief because of restless leg syndrome. It's often associated with difficulty sleeping, getting to sleep, or staying asleep, and then they're tired during the day or sleepy during the day as a result of this. Periodic limb movement disorder oftentimes goes with the restless leg syndrome. These are regular leg jerks or twitches during the night while asleep. So restless leg syndrome would be as you're preparing to go to sleep. Periodic limb movement disorder is while you're asleep. And this is typically in cycles of every 20 to 40 seconds, a person will have leg jerks or twitches or kicks. Again, doesn't usually go over too well with the bed partner if they're getting kicked during the night, but it occurs in phases throughout the night. And again, is no surprise to you, can be associated with difficulty sleeping, daytime fatigue, or outright daytime sleepiness. The common causes of restless legs, alcohol, big offender. Caffeine, our drug of choice, right? Can be a big offender and can make it much worse. Antihistamines, here in Middle Tennessee, we're in what they call the allergy bowl, where people are oftentimes struggling with allergies a lot of the year. And oftentimes they're taking antihistamine medications to try to combat those allergies. And it can make restless leg syndrome symptoms really crop up quickly. Certain types of medications otherwise, SSRIs are medications often used to treat depression and anxiety. These can cause restless leg syndrome symptoms. And then gastrointestinal drugs like reflux medications, certain ones can cause restless leg syndrome symptoms. The type of activity we do during the day can have a big impact on our leg movements at night as well. Particularly, you hear a lot of folks who are on hard surfaces all day long or in work boots and those types of things, and frequently on their feet during the day can cause restless leg syndrome symptoms. And then if you're chronically sleep deprived, that can make the symptoms much worse as well. Ironically, if you have restless leg syndrome, you're much more likely to be chronically sleep deprived, which is going to make the restless leg syndrome worse. So the cycle has to stop at some point. One of the places that we can stop the cycle is to check a person's iron levels. Now, you and I might go to our primary care doctor and get blood work done, and there is a total iron blood content measure on there. They check the iron levels in your blood, but they don't check an iron marker called ferritin. Ferritin has to do with how our body produces iron and distributes iron. And what the research has shown is that low ferritin levels is actually a good thing for people with restless leg syndrome, because you can do iron replacement therapy. It's a pretty good sized dose, 325 milligrams of iron twice a day. And we usually recommend that people take it with vitamin C. They can even take it with a glass of orange juice to help with the absorption. And you do that for 90 days. And 8 or 9 times out of 10, the restless leg syndrome symptoms are gone, and it's permanent. So you've got a lot of doctors out there that are well-intentioned, that are prescribing a lot of medications, heavy-duty medications for restless leg syndrome. Really, it can be fixed with iron over the counter. So it's pretty easy to fix if you think about it from a supplemental standpoint. And the fact that it's a permanent fix is really, really remarkable. You also see the commercials for the restless leg syndrome medications late at night, along with the commercial for the sleep medications otherwise, because they know you're awake, having trouble getting to sleep, watching that and hoping for some type of symptom relief. So to get this fixed, of course, stopping alcohol for a guy like me, that was recommended anyway. So limiting caffeine, tough for a guy like me, but still something worth considering. Considering medication changes, taking a look at activities, trying to do everything to improve sleep in terms of the quality, quantity, and timing. And then checking that iron marker called ferritin on labs is really, really helpful. Again, they mentioned this already. The iron replacement involves 325 milligrams of iron twice a day with vitamin C for 90 days. You kind of recheck the ferritin level, make sure it's up in the normal range, and usually the symptoms are gone and it's a permanent fix. It's amazing. So let's talk a little bit about sleep and addiction as we round out here. Boy, a lot of folks that we see come into treatment for addiction have trouble sleeping. We don't see people typically that call us on a good day. I know when I picked up the phone to go to treatment, it was not the best day of my life. I wasn't on a winning streak when it came to a lot of things in my life. Nutrition, exercise, sleep, anything health and wellness based. Those were just not priorities for me because I was in the throes of a disease, of a substance use disorder. Um, the thing is, sleep problems are pretty common in those with addiction disorders. And it's a chicken and egg question, you know, which came first? Did I start developing sleep problems because of my substance use disorder problem? Well, that would make sense. Did it come with the stressors that kind of are associated with my substance use disorder? That would make sense too. But we do occasionally see people who originally started out with sleep problems and started trying to self-medicate, kind of like we have a tendency to do as human beings. And it eventually developed into a problem with substance abuse, whether it was alcohol use or stimulant medication or whatever it might have been. But the two can be very commonly related. Let's talk about alcohol and the effects of alcohol on sleep as an example. Um, Alcohol actually, in the beginning phases of trying to use alcohol to help with sleep, can actually decrease what we call our sleep latency. It can help people get off to sleep a little more quickly. It's a sedating agent, right? But it decreases our REM or dreaming sleep during the first half of the night and shifts a bunch of it to later in the night. Now, you remember at the beginning of this presentation, I talked about the need for us to cycle through those stages of sleep in a healthy way 4 to 5 times per night. So it immediately throws our sleep staging off. And what it does is, as the alcohol processes out of our system through the night, our body is craving more to get back to sleep. So your brain is constantly rousing you from sleep, and it makes for shallow, disrupted sleep as the night goes on, particularly for those who drink a lot, like I used to. And folks who have an outright alcohol use disorder, eventually it stops working to get them to sleep. It just doesn't sedate the person to sleep anymore. They have a lot of awakenings and they stay awake at night. And it also decreases REM or dreaming sleep, and they really get very, very little deep sleep. So they wake up feeling exhausted in the morning on top of being hungover. So it's really a tough prospect. In summary, alcohol is awful for sleep. So if you ever have a friend or family member that says, oh yeah, I like to have a glass of wine, it helps me sleep at night. Well, that may be true if they're not like me. And it may be true if they're able to stick to that and not have it become a pattern long term. All the scientific evidence out there suggests that alcohol can be helpful pushing a person off to sleep in very low doses for 4 to 7 days. And that's about it. Beyond that, it is awful for our sleep. So for those who are lucky enough, like me, to make it to treatment for addiction, there are other considerations too. During treatment, I didn't sleep well. When I got out of treatment, as I mentioned, I was back on this pathway of early recovery, and there was a lot of wreckage to clean up. I was trying to get back into the workforce. I felt lucky that I had an opportunity to do that, but I was scared to death. I had a lot of relationships that needed repairing, and it was a stressful time, and trouble sleeping was pretty common for me then. Our instinct as human beings is to find a quick fix, right? Especially a guy like me. So as I go in as a patient to see my doctor, telling him about my sleep troubles, there's a little part of me that is looking for something that's going to give me some symptom relief pretty quickly, right? Guess what? On the other side is the person in the white coat, the doctor, who wants to give me some symptom relief. And they probably also have a waiting room full of people and a busy day. And in the interest of giving me some symptom relief, giving me a solution, and moving me along pretty quickly, oftentimes a well-intentioned doctor can end up writing a prescription for something that I don't need to get a prescription for in early recovery. One of the big things we see folks getting prescriptions for is benzodiazepines, your Xanax, your Valium, your Ativan, those drugs that are in that family. And I am benzodiazepine prejudiced. I hate them. because they're so widely used still, and they have such an awful impact long-term and short-term on people's lives. And they're some of the most addictive substances out there in the world, and they're prescribed very commonly to people, even by well-intentioned doctors who are trying to give someone some symptom relief. So that can be a gateway to relapse for somebody who's in early recovery. The take-home message is, number one, medications are not a good first line of treatment for those of us in recovery when it comes to sleep issues, usually, especially certain types of medications. And number two, I made a commitment to engage in what my first sponsor called impeccable honesty. That means when I go in to see my provider at the medical clinic, I'm going to share with him that I'm in early recovery. And, in light of that, I'd like you to be real sensitive to what it is that we discuss in the way of treatments for my sleep issues. So this slide really speaks to that. Whether medication is the solution or not, it really does increase our risk for relapse, can be the gateway to relapse, and is usually not the treatment of choice, particularly for insomnia in us as recovery people, as a population as a whole. There are certain medications, a lot of folks in treatment will get a sleep medication that's now, used to be an old antidepressant, now used basically just for sleep in lower doses, called trazodone, for example. That's pretty safe and can be effective in giving some symptom relief for a period of time. But long term, really the non-drug treatment is the way to go. This is the field called behavioral sleep medicine. And the tools that really can be afforded to us by the right kind of professional are more effective, they last longer, they facilitate our health and well-being, and they will bolster our recovery down the line. It's a big deal to find the right kind of provider who will help stay away from things we don't need and guide us in a direction of doing a little bit of extra work on the front end on our sleep so that it can make our lives easier ultimately down the line. So there are a lot of different options out there in terms of implementing kind of a sleep wellness piece to my recovery program. Getting assessed by people is really pretty critical in this, folks. There are resources out there, and I'll share via Kyle, not just this slide deck, but some links to some websites where you can find the right type of sleep professionals in your area that can recommend some pretty practical interventions. And I always call it the stepped care model. You might be able to fix this with your nurse practitioner or with your physician in their office. And then you kind of step up if they're unable to help you to kind of a sleep specialist. And then you can even specialize more for somebody who might treat sleep apnea versus insomnia versus restless legs and those types of disorders based on their training and experience and knowledge base in those different areas. So in conclusion, sleep disorders are pretty common, actually. They have a substantial impact on our health and our quality of life. It's important for us as recovering people to recognize that the treatment of sleep disorders in us as recovering folks is critical, not just in terms of our health and quality of life, but in terms of boosting our recovery program and keeping us on the right pathway. Really, there are fairly simple tools that can be utilized to incorporate sleep wellness into my recovery program, and always seeking counsel with others by way of kind of that stepped care model can be utilized pretty effectively and pretty easily, ultimately getting me in front of the right specialist by reaching out and asking for help. Boy, that's a tough one for me as a recovering person sometimes, to admit that I might need help with something. Even to this day, with a pretty good number of days in a row in recovery here, that can still be a challenging prospect for me. But if you need help in the sleep world, please don't hesitate to reach out to us at Journey Pure. We have many tools at our disposal that we can recommend for you. And this is not an uncommon thing at all for folks who are in all different phases of recovery. So I'm going to stop sharing my screen here. I just want to leave a few minutes to see if there are any questions or comments related to that. I know that's a lot to digest in one setting here. And if you think of any after the fact too, I want to be sensitive to your time. Please feel free to shoot us questions. Questions, comments, concerns? Looks like Sarah, you've got your hand raised there.
Yeah, I have kind of the opposite problem, I guess. I struggled with insomnia before my addiction
Mhm,
from PTSD. And
mhm,
so I was put on trazodone and I came off of it, and then I started struggling with my addiction. Well, obviously, because of my addiction, my sleeping patterns were all over the place because I was crashing and stuff like that.
mhm.
um, when I started taking a lot of naps during that time because of the crash, and I didn't nap a whole lot before that. Um, but I still haven't been able to get out of that habit. And like in treatment, I would have to go nap for like an hour or two before we had to go do something else. And right now, I'm unemployed and I'm finding myself napping, not even napping. I mean, I guess it's almost another sleeping cycle of 2 or 3 hours of sleep. And I can't seem to break the habit. What do I need to, how can I get out of that so I am only taking those 10, 20 minute naps, or, because it's starting to affect just kind of the way that I live.
Absolutely. And boy, I appreciate you sharing that, Sarah. And I feel your pain. I really do. There are folks who struggle with insomnia, difficulty sleeping. And then there are people who have on the other end of the spectrum what they call hypersomnia. They kind of sleep too much. I'm not sure what your sleep pattern is like at night. If you're sleeping at night and then still sleeping for that block of 2, 3 hours during the day, in addition to
I
that.
am.
Yeah, and that would kind of qualify in that hypersomnia category. I would definitely recommend getting in front of somebody who might be able to assess that in a bit more depth for you. The reason why is there are many, many different factors at play here. If there's a medication you might be on that causes some hypersomnia, some sleepiness during the day, if there are medical issues that might be contributing to that. Mental and emotional issues for all of us contribute to our sleeping patterns, and that could be on the insomnia or hypersomnia side of things. There could be something going on during your sleep at night that's making your sleep fragmented and shallow, such that you're not rested and restored during the day. So by the time you hit early afternoon, you're crashing again and you can't stay awake. It could just be plain and simple, and I've never liked the name of this in this kind of situation, but the behaviorally induced sleep issues that we kind of get ourselves into. It's amazing, isn't it, how quickly we can get into those types of sleep patterns. And we can train our brain really quickly. I'm going to be asleep every day from 1 p.m. to 3 p.m. And then I'm going to go to bed at night at 11 p.m. and get up at 6 a.m. And suddenly that just becomes kind of ingrained really quickly, and it's next to impossible to make it through those afternoon hours without going off to sleep. So some behavioral things would be, and boy, I just talked about caffeine being our drug of choice. I don't know how sensitive you are to it, but some people can effectively time their caffeine use to right before that to give themselves a little bit of a boost. Scheduling activities during that block of time in the afternoon when you would normally be drifting off to sleep. So just some behavioral interventions that are really simple and quick to try to keep yourself awake during that time. And considering getting out to see someone to the extent that you're able or have the capacity, who would be a good sleep specialist to kind of help walk you through that and assess those other factors and how they might be in the equation.
Thank you so much.
Sure. Yeah. Thank you for the question. Other comments or questions?
Brian, when you said uh, insomnia is linked to psychiatric disorders,
Mhm,
um, I'm retired military, and
mhm,
when I come back from a deployment in 2007,
mhm.
you were talking about your biological clock.
Yeah.
So we were awake during the day over there,
Mhm.
which is nighttime here, when our bodies were used to being asleep.
Right.
And then, of course, you would, if you were out on mission, you might go 2, 3, 4 days without any sleep at all.
Mhm.
And when I come home, after that particular deployment, I really had a hard time sleeping. I was in country 15 months.
Mm.
So my body, I guess it got used to being up when it's nighttime here.
Mhm. Mhm.
But is there any studies done to where that could be linked to PTSD?
PTSD is linked to all kinds of things sleep-wise, Richard, not the least of which would be nightmare disorder. So people, of course, when they struggle with post-traumatic stress disorder, have trouble with flashbacks, re-experiencing nightmares are very common. So sleep is generally fragmented and shallow for people who struggle with trauma-based disorders, first and foremost. Boy, you throw on top of that you engaged in this great military service to your country. Only one thing was thrown off related to your sleep about that, and that would be everything. I mean, good grief, how do you sleep when you're out on active duty, deployed in certain situations that are high stress, and you have to be hyper vigilant, and you literally are in fear for your life? It's not conducive to sleeping in that type of setting. Throw on top of that with the other thing that you referenced, Richard, which is another circadian rhythm disorder, which is a jet lag type phenomenon. So if you've moved more than 2 time zones outside of your home sleeping environment, so if you and I got on a plane and went to Los Angeles tomorrow, 2 hours behind us, right? We are at risk of having a circadian rhythm disorder known as jet lag disorder. And that's because we're out of our normal timing in terms of our sleep. And suddenly we have to adapt to light and dark in that new time setting. So you were maybe halfway around the world, let's say, and things were kind of flip-flopped. Our bodies will typically adapt to that part, and then they have to adapt back when you return home, but that can take some time, weeks or even months for people. So you, man, oh man, as part of your military service, you had kind of a triple or quadruple whammy really on your sleep, with the trauma piece, the scheduling piece, the circadian rhythm piece. Getting all of that stuff kind of realigned can be a life changer, I think. How are you sleeping now?
I appreciate it. Thank you, Brian.
Yeah. How are you sleeping now?
Good.
Oh, good. Good.
I sleep good now, and especially with not drinking has helped tremendously.
Oh,
Tremendously.
yeah. Isn't that amazing? Yeah. When I quit drinking, I thought, oh, it'll have the opposite impact. I won't be able to sleep anymore. And actually,
Yes.
if nothing else, it took all of the day-to-day just absolute angst out of my mind about where my life was headed and the wreckage I was causing. So, yeah, it's a big deal, man. Thank you for that. Any other comments or questions?
Thank you.
Yeah, my pleasure. I really appreciate y'all being here tonight. We have recorded this. We'll probably redistribute it again. Any questions or comments, please reach out to the alumni team. I'm always happy to jump back on calls, answer questions personally, hop on the phone with people who need consultation related to this stuff. Happy to help any way I can.